conversations titled Aging Gracefully, Safe and Sound Advice. It is Better Speech and Hearing Month, so we have a talented pool of community experts. The first is Peter White, who happens to be my husband. I'm Ann White. So Peter's an ear, nose, and throat surgeon at Meadville Medical Center. We have Barb Wetzel, who is one of our two audiologists. They have doctorates in audiology, so Barb is here with many years of clinical experience as well. And Kelly Anzaldi is one of our occupational therapists at Meadville Medical Center. So this is meant to be an informal community conversation, so make yourself comfortable, and Peter, I'll let you go ahead and get started. Thank you.
Okay. So as Ann said, this is meant to be a community conversation. We were given 10 minutes each to talk, and we'll field questions at the end, but please don't hesitate to interrupt us as well. That won't bother us at all. So I was given 3 topics to cover in 10 minutes. The middle one, I can quite assure you, you could go to a 1-week conference on and not cover the whole thing. So the purpose really is to hopefully generate some interest and some questions in the audience. I was asked to cover these topics because I'm the physician in the group, and they are, I guess, physician-related topics. Now, I don't know in the group here who remembers basic health class, but this is a picture of an ear, and this is obviously the outside part, which is called the pinna and the ear canal, and then you've got an eardrum and some little bones of hearing, and you've got an inner ear. In your inner ear, you have 2 basic structures. You have an inner ear balance mechanism and an inner ear hearing mechanism, the snail-like structure there. Here is the hearing part, and the balance part are these canals. They're called semicircular canals. So aging hearing, as I said, I'm just going to make some basic points about this. And I would like to start by saying it's not normal for you to lose hearing as you age. I regularly see people in their 80s and occasionally in their 90s with still well-preserved, good hearing in the normal range. So to sit at home with poor hearing and not consider any kind of help, I would suggest to you is probably not what you want to be doing. Speech discrimination, let me explain that. It's really the earliest problem you notice with your hearing. And the word, or the 2 words mean you lose your ability to discriminate the tones that make up a word, so that the tones become blurred, so that the word becomes blurred. And at 55, I know I have a little bit of this, but probably still have a relatively good-looking hearing test. And so fall sounds like call, sounds like ball, sounds like mall, and was it fall or call or ball, or I heard it, but I didn't quite make it out. And that's really when you're starting to have a little bit of a decline in your hearing, and that gets significantly worse at the Christmas party. So there are 25 people in the room like this, except they're all talking, their Christmas carols going, the choo-choo train is going around, and the Christmas tree, and that person is 2 or 3 feet in front of you, and you're looking at them like, I heard what they're saying, but I'm not sure I quite make that out. And that's early nerve hearing loss. Most hearing in older people is either an aging or a decline with age in hearing, or noise induced. And certainly in an area like this where we've got a lot of industry, there are people who have had a fair bit of noise exposure that can contribute to deterioration in their hearing. And then, of course, we live in a hunting and shooting culture, and a lot of noise exposure can contribute to decrease in hearing. And then, of course, as the noise-exposed people age, they get a combination of the two. And those would be the two most common causes that we would see for decreased hearing. Some of you may be surprised to find out that the rate at which your hearing ages is, at least for some people, in their genes. And I saw a lady at 2 o'clock this afternoon who was 82 years old, and she had had hearing aids for the last 15 years, and her brother and sister had had the same from about the same age. Not necessarily, but it can run in families. And I would also like to say, and I hear this regularly, and I'm sure Barb does as well, I'm too old to get hearing aids. After all, I'm almost dead. Well, you know, I say to these people, I am not a life insurance agent, but you're on one blood pressure medication, you're 86 years old, and you probably have a life expectancy of 10 years at that point. Maybe at least. And it's really a lifestyle or a quality of life issue to try and maximize the hearing you've got, and I would encourage people to consider some help. Now, as I mentioned, aging balance, that's a big topic, and I am, again, only just hoping to generate a little bit of conversation only. I would start by telling people that even mental issues or psychiatric issues can generate instability or poor balance, dementia and depression, and even just the anxiety, the fear of falling can make older people feel unstable. Heart problems, abnormal rhythms of the heart so you don't perfuse your brain and it makes you lightheaded, and poor circulation from blocked arteries. Of course, orthopedic problems change your gait and can contribute to falls and instability, arthritis, joint problems, the weakness and decreased range of motion of your joints, and you just don't quite get that foot up over the curb and you trip and fall. Of course, neurologic issues like strokes that contribute to altered muscle strength and tone, and altered reflexes, tremor, Parkinson's disease being the most common one, altered brain function from things like strokes, and of course then there are altered nerve sensation, principally in your feet. The most common cause of that would be diabetes, where people get altered sensation and therefore have some instability and have trouble maintaining balance. Goes without saying that if you can't see, it gets pretty hard sometimes to maintain your balance, and tripping and falling is easier, and it's also if you can't hear. Now, partly because it's what we're talking about tonight, vestibular problems means inner ear problems, and I'll touch on the most common inner ear diagnosis in a moment. Increased weight or obesity certainly makes it more difficult to maintain balance. Of course, medications, either new medications or if you've had a change in the dosage of your blood pressure medication and your blood pressure runs a little bit too low at times, abuse of prescription drugs, and of course abuse of non-prescription drugs can contribute to falls in older people, and alcohol. And I stop there. That list could go on and on and on. I don't think it's fair to say that anything that affects you physically or mentally can increase your fall risk, but certainly many things can. Many of the people who have trouble have more than one diagnosis. At least 75 to 80% of people, if you look at their fall risk, are going to have more than one problem contributing to their risk of falls. Okay, so now we're getting, as an ear, nose, and throat doctor, you're getting into something that I am more expert in, and this is a vestibular illness, and this is called BPV or BPPV, and I have patients coming in telling me they have rocks in their head or stones in their ears. Perhaps the most common description is they've heard that their crystals are out of place, and that's perhaps the most appropriate description of the problem. And what happens is that some naturally occurring crystals in your inner ear, they are supposed to be there, but they become broken off and they start floating around in your balance mechanism, and they float into a position in your balance mechanism where they're not supposed to be. And you put your head back into a certain position and it starts bumping up against some of the sensory fibers in your balance mechanism and starts stimulating it. And it's abnormal stimulation. And in your inner ear, that generates what's called vertigo. And vertigo means an illusion of movement of yourself or the surroundings around yourself. And so you get a spinning feeling, and occasionally sometimes some nausea associated with that. And you move your head out of the position and the stimulation stops and it goes away. So we're all old enough here to talk about textbooks and not the internet, but so the textbook would say that when you go to get into bed at night and you extend your neck and put your head back on the pillow, you spin and take your head out of the position and it goes away. You're changing the oil in the car, you're going to get something off the top shelf at the grocery store and looking up. Sometimes it occurs when you're bending over. The wonderful thing about this problem is we can actually do something about it. I can't necessarily fix your stroke, I can't reverse your arthritis, but we can, through a relatively simple head manipulation, take those crystals out of the part of the ear where they're bothersome and put them back into the part of the ear where they're supposed to be, and not so bothersome. So again, the really nice part about that is I, and more importantly the patient, gets a relatively instant gratification of fixing that part of their balance problem. And I have a little video that shows that a little bit. It's just 1 minute long.
Benign paroxysmal positional vertigo, also known as BPPV, is one of the most common causes of dizziness. There are two types of balance organs in the inner ear, the semicircular canals and the otolith organs. The otolith organs contain crystals of calcium carbonate, which are constantly being shed, dissolved, and replaced by new ones. If too many crystals fall off at one time, and the patient looks up or lies down before they dissolve, they can fall into one of the semicircular canals. When the patient rises, they don't fall out, they fall in and become trapped in the canal. Upon lying down, the crystals fall through the canal, causing an intense spinning that lasts a few seconds until the crystals fall to the lowest point. When rising, the crystals fall in the other direction, which again triggers dizziness. Until the crystals are dissolved, the canal may not work properly, and chronic disequilibrium as well as positional vertigo may be present. This will continue until the crystals in the canal dissolve or are moved out of the canal with special exercises or maneuvers. Even untreated, most cases of BPPV resolve within 14 days.
Who's next?
multitask. Thank you for coming here today. I would like to introduce you to, or perhaps refresh your memory about having a hearing test, and then talk more about vestibular testing that we offer. As you saw previously, there's a diagram of the ear, and the hearing loss and dizziness, those centers are in the purple area, the semicircular canals, or the inner ear structure, the cochlea that's shaped like the seashell or the snail. When you come for a hearing assessment, it's important to bring a friend, a spouse, a son, or a daughter. So don't feel that you have to go this alone, because having someone there with you will help you get the most out of that experience. Perhaps you don't realize what you're not hearing, and that person, your communication partner, could bring some things to that appointment so that you could benefit the most from your hearing test. Often we use self-assessment scales, and you have some on the handout there. Self-assessment will let you rate your hearing problem as to how much certain things bother you. For example, do you have difficulty hearing the television, or do you have difficulty hearing when someone speaks in a whisper? If you had someone with you, they would point out that you may have difficulty hearing someone speak in a whisper, and you would have missed that. You would have just thought that nobody whispered to you. So having that self-assessment brings about some topics for conversation so that the audiologist can help address all of the problem areas for you. When you have a hearing test, which you may remember having at a doctor's office, or I do see some patients that say they haven't had a hearing test since school. So the hearing test that we are most familiar with would be the one where we listen for tones and then respond to the tone. And many people would say, well, I have an okay ability to hear those tones, but I have difficulty understanding what people say. And that made me think that maybe people don't realize that we test the speech understanding also. So the audiogram that is on the screen there will show you that's where we record the hearing test. And your scores would be considered better hearing if they were lower. So 0 would be perfectly normal, and going down the scale from green down to purple would be meaning that you had more hearing loss. Conversation takes place approximately in the middle. Going across the graph from left to right would be the pitch of the tones that you heard. On the next slide there, it's an audiogram that shows normal hearing. So the red line at the top where the scores are low, that indicates that person has normal hearing. They could hear everything that's on the graph below that red line. So they could hear water dripping, dogs barking, a motorcycle. The light blue shaded area shows normal level conversational speech. So that person would be able to hear all of normal level conversational speech. The next graph shows hearing loss. And if you'll notice, it slants downward in the higher pitches. And this person would have difficulty hearing certain sounds like P, H, G, TH. So just like Dr. White mentioned, they would have difficulty telling one word from another, like ball from fall. They are hearing some of the softer sounds, but not the louder sounds that help them understand speech. These people would say, well, I can hear someone talking, but I'm not understanding them. We do tests that indicate how well you hear and understand speech. Speech audiometry uses a familiar test signal. When you take a hearing test, it's an unfamiliar signal. You're not used to listening to tones in a room and pressing a button when you hear those tones, but you are used to listening to speech. And by your responses to speech, we can tell that you are doing the test with the tones correctly. So when you respond to the tones, we get a certain value, and that value or that number is used when we want to see how well you hear speech. So we compare the two scores. You should hear the speech at the same level you hear the tones. And we go on to test about speech discrimination or word recognition, how well you hear speech in a quiet situation. And that provides information about how you would do if you wore hearing aids, because we can test your ability to hear speech and then make that speech louder to see how well you understand it. By having amplified speech, do you do better? That's what we would want to know. If you wore a hearing aid, would you actually understand better? So this speech testing helps us understand how well you understand in quiet, how well you understand when speech is made louder for you with a hearing aid. And we also do some tests that have noise in the background. Just like Dr. White mentioned about the Christmas party. How well would you understand speech at a Christmas party, for example? The noise in the background makes it difficult for you to understand what's being said, particularly when you have hearing loss. But there are normal hearing people that have difficulty understanding speech and noise. When I look at an audiogram, I can't predict how well you'll hear and understand speech in a noisy environment. It needs to be tested. When we gather that information, it helps us determine how well you would do with features of a hearing aid, special microphones or other equipment that works in conjunction with hearing aids. People wear hearing aids, and hearing aids help them hear better. Their best performance with the hearing aid is when they are 6 feet or less from the person talking to them. When they increase that distance, then their speech understanding may become compromised. There are devices that work with hearing aids wirelessly so that you can preserve your speech understanding and do well in a noisy environment. For example, it's possible to have a wireless receiver that would receive a signal from a microphone. For example, I would wear the microphone today, and if you had hearing aids and that wireless receiver, you would get a very clear signal at a distance. So someone at the back of the room, more than that critical distance of 6 feet, they would get a very clear signal directly into their hearing aids. So we gather a lot of information from speech testing in quiet and speech testing in noise to help you choose a hearing aid that would work well for you. The Better Hearing Institute reports consequences of untreated hearing loss. If you don't treat your hearing loss, you could, over time, develop negativism, become irritable, experience fatigue and tension and stress, feel lonely because you're not doing the social things that you would normally do, notice reduced alertness and personal safety. Do you hear the doorbell? Do you hear the phone ring or the smoke detector? And just overall diminished health. By treating your hearing loss, you could help to reduce those negative consequences, and those are bonus, and in addition to having the treatment for the hearing loss. It'll help you hear better, but to reduce fatigue, tension, stress, and give you more of access to social situations would be a definite benefit. By not treating your hearing loss, you would miss out on social events in life, and treatment of hearing loss would help with communication in relationships, increase your socialization. For example, maybe you don't go to church or meetings that you used to go to because you don't hear as well. You would feel more of a sense of control over your life events because you were more part of the conversation, more part of conversations with physicians, and feel more alert. Improve your mood by reducing anxiety and feel less depressed. Improve confidence because you feel like you're getting the message, just like when you didn't understand something and then the light came on. So it would improve your confidence by feeling that you are communicating as best you can. Improve your safety by alerting you to things around the home, noises that you should be hearing, like the phone and the doorbell, and make it easier to communicate. Think about a time when you've been communicating with someone who speaks with an accent and how much work that is. It's the same amount of work, or maybe even more, when you have hearing loss and you are trying to communicate. So by treating your hearing loss, you can improve a lot of those things to improve your quality of life. Should you have an audiology evaluation or a hearing test? On the following slides, there are some questions, and they're also on a handout on your table. You don't have to answer them now, but think to yourself as I read through them. The handout would also be helpful for you to take to your communication partner if they're not here today. If you both fill out the questionnaire about yourself, you would have likely different answers from the person that you communicate with the most. So should you have a hearing test? If you could answer yes to 3 or more of the following questions. Do you feel embarrassed when you meet new people? Frustrated when talking to members of your family? Difficulty hearing? Difficulty talking with coworkers, clients, or customers? Do you attend religious services less often than you would like? You can think to yourself, am I answering yes or no to these? So 3 or more would indicate you should have a hearing test. It goes on to say, do you feel slowed down? Do you have difficulty when visiting with friends or relatives? Have arguments with family members? Difficulty listening to TV or radio? Do you want that volume turned up, and that would then cause problems for other people trying to listen to the same station? Does it limit or hamper your personal or social life? I particularly like that question. You may say it doesn't, but the person you communicate with, they may say it does because they're not talking to you as much because they have to repeat themselves, or they have to talk louder, or maybe they would choose to not go to the movies because they have to repeat things. So that's why I think it's nice if you take those questions seriously and ask them to another person that you communicate with. Do you have difficulty hearing when you are in a restaurant with relatives or friends? So if you could answer 3 or more of those with yes, you may want to talk to your physician about having a hearing test. On to the vestibular assessments. Audiologists often do vestibular assessments, and I'll mention the 2 that we have. This is a picture of video goggles for the test called video nystagmography, or electronystagmography, whether the patient wears video goggles or electrodes. And it's one of those things you have to experience. You wear goggles or electrodes and watch a light move across a bar in front of you, move your head into different positions, and at the very end, your ear is stimulated with air or water for a minute, and that gives you the sensation of moving. The total test takes maybe an hour. It does test the vestibular system in your ear. It's one of the services that we offer, and that is Ashley, the other audiologist, gracious enough to model for us. And the next test is video head impulse testing. This test takes 20 minutes, and it's not as involved. Instead of you moving or having your ear stimulated with air or water, you would wear goggles and focus on a target in front of you. So you would look at a spot on the wall in front of you, and the audiologist would turn your head in short movements. The advantage of this test would be that it's 20 minutes. There's no prep. People would feel it would be more comfortable. You may be able to have it done on the same day that you come in for a hearing test. It can be done on a relatively short notice. But it also tests the inner ear, the vestibular system of your inner ear. Many people experiencing dizziness may not realize that we have inner ear tests available to see if that's the cause of the dizziness. To show you that we offer those 2 tests, your doctor would choose the most appropriate one for you. It's not that I'm trying to compare one to the other as one is better. They're just different tests that we offer to assess your inner ear. Just like Dr. White mentioned, there are many causes of dizziness, but if your doctor suspects it's an inner ear cause, then you would likely come for one of these tests. If you have vertigo, dizziness, or lightheadedness, then you may be seen for one of those tests. Any questions for me before we go on to Kelly?
Water and air in the ear. Why would you? Why would you?
Sometimes people have a hole in their tympanic membrane, their eardrum, and they couldn't be tested with water, so air would be more appropriate. Patients feel that air is more comfortable than water. They both have the same effect on the ear. Some examiners would choose water over air.
What if you have, I'm pronouncing this wrong, but it's tinnitus or tinnitus in your ear, completely ringing in your ear?
That may accompany hearing loss, and it may be a sign of many other conditions or a result of many other.
Well, is there treatment though? Is there treatment for it?
Is there treatment for the tinnitus? Sometimes, yes. It depends on what causes the tinnitus. It can be related to medication or other health conditions. Audiologists often treat tinnitus. You may notice less tinnitus when you wear a hearing aid. Okay. We'll go on to Kelly to talk. Kelly is an occupational therapist. Probably be faster.
Okay, thank you. All right, so as Barb said, my name's Kelly. I'm an occupational therapist at the Meadville Medical Center. And I'm going to be talking about fall prevention and things that you can do in your home to keep you safe from falls. So Dr. White kind of went over some of things that can cause falls, some risks. Intrinsic factors are things that are within our body that might be changing as we get older. So things such as decreased strength, decreased balance, decreased mental functions such as poor problem solving or poor safety awareness. Acute and chronic diseases, like he said, stroke, Parkinson's disease, things like that. Sensory deficits, which is like your neuropathy, which is caused a lot of the times by diabetes. Orthostatic hypotension, so this is when you become dizzy when you stand up too quickly, or the BPPV, which is the dizziness that Dr. White was covering earlier. Decreased reaction times, a history of fall, and then getting older or increased age. Some factors that are outside of our body, which would be extrinsic, would be polypharmacy, which is taking multiple medications, environmental factors, alcohol abuse, and then things we do in our daily tasks, such as climb the stairs or get in and out of the bathtub. I'll focus mostly on the environmental factors today. So common mechanisms of falls during daily tasks. Standing while dressing. I work at the transitional care unit mostly, and I always encourage patients to be sitting down when they get dressed. Sometimes, we're in a hurry and we want to just slip our shoes on, but it's so important that you sit down, take your time and not be hurrying. Climbing on step stools. We find this a lot in the kitchen. Now sometimes there are things that are out of reach. I'll cover that further down in the presentation, what we can do for that. Transferring in and out of the bathtub. This is a really unsafe task because the floor can be slippery. We want to take major cautions when we're doing that. Reaching into high or low cupboards, and then our toilet routines. General environment modifications, really important ones: remove your throw rugs. Your toe can get caught on the edges and that can be a big tripping hazard. Replace or remove torn or lifted carpeting. Avoid thick carpeting. Improve lighting within your houses. Have night lights for in the nighttime. Ensure that the pathways aren't cluttered. Use glow-in-the-dark switches so that you can see when you go into a possibly dark room. Keep electrical cords tacked against the wall and not in any walkways. If you have an assistive device that your physician or your physical therapist may have prescribed you want to be using that in the home. We don't want to see people furniture surfing or grabbing onto things to get around the house. And finally, you want to either be carrying a phone with you in your pocket. Cell phones are so much smaller these days, it's easier to carry around, or have a life alert button. So things that we can change in our homes. With the stairs, we want to make sure that we have handrails at least on one side. Better yet would be on both sides. Make sure that you have good lighting going up the stairs. If your stairs are wooden, make sure you have non-slip surfaces. And then maybe outdoor steps, you might want to think about having a bright line or like a reflecting tape outside so that you don't trip on the edges. In the kitchen, you want to make sure that you have your commonly used items at counter level or within reach. So cups, plates, bowls, things that you use all the time. Make sure that they're really accessible, because that's when we find that people start using step stools, and that's a major tripping hazard at home. There are reachers and grabbers out there, all kinds of different kinds. They're very helpful for lighter objects. We don't want people using those for heavier things from the top shelf, though. If you have a family member or close friend, and you're planning on doing some heavier cooking, have them bring down the mixing bowls and things that might be stored up high so that you can get to them safely. If you need to use a step stool, they have sturdy ones that do have handrails on them if you don't have anyone to help you out in the kitchen. And finally, make sure all your cupboard doors are closed and drawers are closed. Sometimes we're cooking and doing things really quickly. We leave them open, and then you might bump your head on it or trip over a drawer that might be open. So make sure we're closing those. In the bathroom, you want to make sure that you have a non-slip mat in the tub or the shower. Install grab bars around the toilet and especially in the shower area. We don't ever want people to be using the towel bars as grab bars. They're literally just for washcloths, just for towels, and they won't support the weight, which is a major hazard. Use a shower seat or a tub bench. There's lots of really safe equipment to help you out for a safe shower routine at home. If you're having troubles getting off the low toilet, you might want to get a riser, or like I said earlier, the grab bars near the toilet. Something I was found very interesting: leave the bathroom door unlocked. If anything happens, if you do have a fall, your family member or somebody can get in there and help you out a little bit more easily. And also, do not rush to the bathroom. A lot of urgency. We find people are rushing, and that's when they get tripped up over their feet and then might have a fall at home. In the bedroom, we want to avoid wearing full-length robes or the robes that might have the really long ties that might trip us up under our toes. I put these really cute slippers on here because we want to kind of avoid these too. You want to have something that has a back to them, something that's going to be very safe for you to be wearing at home and not scuffing around in slip-on slippers. Again, make sure you have open pathways. Sometimes in the bedroom, we might toss off our shirt and leave it on the floor. You want to make sure that you're getting those up and not leaving those on the floor. Glasses, if you have prescribed glasses, try to wear them. Those are important so that you can see what's going on in your environment. Caution when sitting. So be careful if you're sitting down in a chair that has wheels on it. If there's handles, make sure you reach back for the handles on the chair so that's there behind you and that it's not going to move whenever you go to sit down in it. So what if a fall does occur at home? The first thing you want to do is remain calm and assess the situation. That might be challenging, but you really do want to just kind of calm yourself and be like, okay, now what do I need to do? Okay, you want to make the decision whether you can get up safely. If you think you can get up safely, if you're not in a lot of pain, you want to get to a sturdy piece of furniture, which I have some pictures on the next slide that'll help you out with that. If you cannot get up, the first thing you want to do is either use that cell phone that's in your pocket or your first alert button, your personal response system, and make that phone call so you can get help as soon as you can. If you don't have a first alert, don't have a phone, unable to get there, you just want to make some noise as loud as you can. You know, there's probably neighbors close by. Somebody might be out walking their dog or something to that effect. So to get somebody's attention. So these little pictures here are showing this lady who happened to have a fall at home, and she's assessed her situation and realized that she thinks everything's okay, she's not in pain. So from number 1, she's laying on the floor. She wants to get closer to the chair in the picture number 2. And then once she's there, she wants to get up on her knees and use that sturdy chair to help get herself up in there. So is my family or loved one at risk for falls? I provided a short handout that has some questions on it about whether you or a family or a loved one might be at risk for some falls. I found this at the CDC website, Center for Disease Control, so this information's out there on the website, you know, if you're looking for more information. But basically it goes through a lot of the things we've talked about already. Have you had falls in the past? If you say yes, then you're probably more likely to have a fall in the future. If you take 4 or more prescription medications, if you have a difficulty walking or standing, if you use an assistive device, if you have dizziness or feel unsteady on your feet. So items such as that. And this handout's nice because it tells you, if you check the yes box, some things that you can do to help that situation and help prevent falls at home. So these are some of the links that I use: National Institute on Aging, and like I said, the Center for Disease Control. Lots of good information on those websites. And that is all. So if anybody has any questions for me or any of the other presenters, we can answer them for you. Good. Yes.
Could minor dizziness from standing up in a sitting position or from turning quickly, could that be a symptom of BPPV?
Do you want to answer that? So his question was if standing up from a sitting position too quickly or turning and becoming dizzy, if that's a symptom of the BPPV that was spoken about earlier. And I'll let Dr. White answer.
So we describe the condition fairly simply, but the reality of it is that it doesn't necessarily show up the same in, or what we say in medicine, present the same in everyone. Now you described 2 separate movements there. One was standing up quickly. Typically that's because you don't get enough blood up into your brain and the blood pressure doesn't adjust properly. And then you said turning. And again, those are 2 different movements. The turning would be more commonly associated with the benign positional vertigo, but I have been fooled by patients who come in and say they get lightheaded when they stand up, and you test them and they have benign positional vertigo. Now they may have both problems, but like a lot of things in medicine, it's not necessarily quite as straightforward as the slides suggest. That's maybe why you go to school for a while, to learn about these things. Tinnitus. So it is my firm belief that this is a wonderful democracy. However, when we're talking about tinnitus, I think we need a benevolent dictator. Because you would think for a problem that does not have a very good treatment, which is often true, not always true as Barb said, but often true, there would be very few treatments. But in fact, because of our capitalistic society, you have a very common problem that doesn't have a very good treatment. There are many, many treatments, some of which are pure snake oil, And you open up any AARP magazine, which I of course never do because I'm not old enough. You can see, I'm sure in the back, some sort of drop treatment. Buy these drops for ringing in the ears. And what I say to my patients is, make sure you don't spend a whole lot of money, and make sure you're not going to hurt yourself. And if you want to try some of these things, then I think that's reasonable. But overall, there is no easy, great treatment most of the time. That doesn't mean there's nothing we can do for people who are very troubled, but the best first treatment is go home and live with it if it's not too bothersome. Any other questions we can answer for anybody? Well, we'll be around afterwards if anyone wants to ask us any questions. Thank you.
Thank you.